Good afternoon. Good afternoon. My name is Rasheera Dopson, and I will be providing a brief presentation on behalf of the National Center of Primary Care here at Morehouse School of Medicine in our most recent research study entitled Assessing Telehealth Experiences to Advance Health Equity for People with Disabilities in Georgia in a Post-COVID-19 Era. As we know, this conversation has been ongoing during the COVID-19 pandemic and its impact on vulnerable population groups. It is from this study that we hope to inform stakeholders and policymakers on the importance of telehealth usage and how we can utilize technological options to advance health equity. And as a brief visual description, I am an African American woman. I am wearing a blue blazer and my hair is pulled back into two buns, and my background has some pictures and a lamp in the desk. We can move to the next slide, please. And so just a general overview of what we will be covering today. Our agenda entails our introduction, which I just completed, an overview of Morehouse School of Medicine, about the study, our focus group surveys, and key takeaways. Next slide, please. So about Morehouse School of Medicine. Morehouse School of Medicine is located here in the Atlanta, Georgia area and was founded in 1975 as the medical education program at Morehouse College. In 1981, MSM became an independent chartered institution and has since become the nation's leading educator of primary care physicians, specifically with Black male physicians, and has been recognized as one of the top institutions in the U.S. medical schools for our social mission, which also include improving health and well-being of individuals and communities, increasing the diversity of health professionals and scientific workforce, addressing primary health care through programs in education, research, and service, with the emphasis of people of color and the underserved urban and rural populations in Georgia, the nation, and the world. Next slide, please. So a little bit about this study. This study was made possible through the partnership through the Georgia Council of Developmental Disabilities and the National Center of Primary Care. We were awarded a one-year grant to assess the adoption and use of telehealth and other virtual delivery services by people with disabilities, including their families and direct support professionals in Georgia. This study also highlights the disparate impact of COVID-19 pandemic on minority and underserved communities before and during the COVID-19 pandemic. Next slide, please. So let's get into the study, our focus groups. So we employed a multi-method approach of consisting surveys and focus groups of people with disabilities, their family members, and direct support professionals in Georgia. We also used descriptive analysis of telehealth policy interventions in Southeastern states related to access and utilization during COVID-19 to inform Georgia policies that will advance health equity for people with disabilities living in Georgia. And looking at the specific demographics found within the study, we have a brief overview of our audience, which gives us more insight into who is utilizing telehealth and where these people are located. So we were able to conduct a total of 6 focus groups with a total of 16 participants via video Zoom conferencing. Next slide, please. And then we see here we have some self-identification factors such as age, such as the people with disabilities, their age, and we also want to notate that our participants were also 50% male and 50% female. Next slide, please. And then in looking at our racial demographics, we also have that our participants were majority white, with 12% reporting to be Hispanic and Latino. Next slide. And then here we have also listed the different disability types that were reported in the study, with the top 3 being autism, other, and spina bifida. Next slide. And then one of the questions that we also included during the study was asking our participants their enthusiasm around surrounding the use of telehealth, in which we see here that 44% had a neutral response to their engagement and their enthusiasm in looking at telehealth. Next slide. And so these quotes in our focus group, we were able to pull back feedback in real time from constituents across the state of Georgia. And so in our first quote, next slide, it states, telehealth makes life easier for parents of child with so many needs. It's one less thing I have to worry about. And we hear from a parent with a child with a developmental disability. And then the second quote, relationships matter with your telehealth provider. The uses of patient portals to maintain health-related relationships is really important. Hearing this feedback like this provides much context to healthcare providers about the different barriers parents and caregivers can face in accessing healthcare, and how we must always be attentive to the needs of patients and making patient-centered care our primary focus. Next slide. And so let's get more into the specifics in our survey portion of the study. Next slide. So just like in our focus group, we kind of see similar demographics. We do notate that in our online survey specifically, there was a high percentage of participants aged 60 to 69. Next slide. And then here we have a more diverse mixture with participants being majority white and also African American. Next slide. And then here we have that participants were also located and living in urban and suburban areas. Next slide. And then in moving away from some of the demographic specifics of the study, we also wanted to highlight key points in which we learned from the study, such as insurance statuses. And so here we have participants which noted 86% of respondents have health insurance, and we have the breakdown listed here on the left side. Next slide. And then in this particular slide, we have the caregiver portion of the slides, in which we had participants who reported having a caregiver or needing support, in which 67% of participants reported having a caregiver, and then 45% listing their parent as their specific caregiver. Next slide. And so in this portion, we're going to be looking more into telehealth access and usage. Thank you. And so we see on the left that different platforms in which telehealth was used, such as phone, audio only, regular telephone, computer. And this report shows that 88% of participants reported using telehealth services since the start of the pandemic. Next slide. And then in this slide, it looks at the access and accommodations portions of the study that we looked at, with 24% of participants reported needing accommodations and support to access telehealth services due to difficulty hearing. And then 14% needed accommodations due to difficulty seeing. And then 66% of participants were able to access all of these stated accommodations for telehealth services. Next slide. And in this particular slide, we're looking at the geographical insights where participants were located, where a majority of participants during the study, they were located in their home while receiving telehealth services. Also, while 67% also reported that their visits were also covered by their insurance companies. And we have the breakdowns listed here. And so telehealth usage in the future. Lastly, looking at the use of telehealth and what will it look like in the future. The use of telehealth services provided can be seen as being satisfactory, in which 72% stated that they would use telehealth services in the near future. And we can see how impactful this study has been, and as it will continue to be as we continue to expand the conversation on using technology as a bridge to equity. Next slide. And so our key takeaways, next slide. So our key takeaways are, our findings demonstrate significant use of and satisfaction with telehealth services by people with disabilities. However, we do note that there are some challenges that exist, especially among those who are living in rural areas and those who identify as being uninsured. People with disabilities were most satisfied with their telehealth services and their experiences, and they said that they felt more engaged, they felt more heard and supported by their providers, and it was also quicker and easier access to appointments. And we see some of that from the quotes that we were able to gather from our focus group meetings. Next slide. Some of the health equity implications. So for participants who have not accessed telehealth services, some of the reasons were that their insurance would not cover these services, the lack of additional services and support, such as having interpreters, ASL, audio hearing services, or telehealth was simply not offered by their provider, or they did not have the right technology to connect to telehealth services. We also noticed that digital literacy when using video and audio devices was a huge barrier for people with disabilities, which highlights the need for on-demand technical assistance in more accessible formats. Next slide. And so some of our policy implications when looking at this study, of course, a permanent expansion of telehealth, knowing that 72% were satisfied and that telehealth is something that definitely should be in the future. Expanding broadband access to residents, especially those who live in rural areas, and accessing telehealth video calls. Again, accessing support to staff in assisted living environments, such as nursing facilities, caregivers, and medical providers. Again, making sure individuals with disabilities have that additional support when needed when logging in for their appointments, and then increasing in digital literacy and updates in technology, ensuring that providers and practitioners are in compliant with the Americans with Disabilities Act and making sure that all platforms are equally accessible. Next slide. So that will conclude this brief presentation. And if you should have any questions, we'll be sure to connect you with the right tools so you can see the full presentation of our study. Thank you.
Thank you so much, Rasheera, for that wonderful presentation and for really highlighting the results of our study. Our wonderful partners at the Georgia Council for Developmental Disabilities really helped us to really engage with all of those partners and people with disabilities throughout Georgia. So thank you, Rasheera. You're such a great asset and great help during that time. Now we're going to hear from our wonderful panel of experts, advocates, and leaders in policy and the population of looking at people with disabilities. And so first, I want to just introduce Ms. Jessica Baker. Jessica currently resides in Tucker, Georgia. She is a proud mother of 4 children, with 2 of whom have disabilities. Jessica works for DeKalb County School District in Stone Mountain, Georgia, and she is actively involved within her community, serving on the executive board for her children's PTSA, as well as doing various community services, and also through her sorority and also with her church. Jessica's favorite quote is, "What lies behind us and what lies before us are tiny matters compared to what lies within us." And that is from Ralph Waldo Emerson. So thank you so much, Jessica, for joining us. Also, we have Mr. Michael Bray. Michael Bray is the Associate Director for Dissemination and Technology within the Michigan Developmental Institute in Detroit, Michigan. He is also the Training Director for the Michigan LIN program. Michael is an instructional designer, researcher, and data analyst by trade, and has worked in the developmental disability field since 2003. His primary area of interest lies in the design and implementation of inclusive, accessible learning environments that enable diverse adult learners to develop new skills and knowledge. Michael's approach to instruction and design is rooted in constructivist theory, taking into consideration the importance of the lived experiences and unique abilities that individuals bring to the learning environment. He lives in Oxford, Michigan with his wife and 2 daughters. And then finally, we want to reintroduce our wonderful presenter and who will also be serving as a panelist, Ms. Rasheera Dopson. She is a disability justice advocate, researcher, content creator, and scholar. She shares both her professional and lived experiences in living with a disability and chronic health conditions. And so I just want to thank our wonderful panel for being with us today. and we're just going to facilitate some wonderful conversations. And so my first, and I will first start out asking Jessica, is what does disability and advocacy mean to you? So just share some of your lived experiences being a parent and a mother of children with disabilities.
Thanks so much, Mitchell. So to me, disabilities means that there is something unique about an individual. I don't look at it as a downfall to an individual, especially my children. I've always treated them as if they're normal, because I don't want them to look at it as it being something that's going to withhold them or hold them back from being able to enjoy the day-to-day life that everybody else gets to enjoy. I'm a very, very big advocate in that, looking at everybody as if they are normal in a sense, even though there may be some. I have one child that has some physical disabilities and one that has developmental disabilities, but I do treat all of my children the same, and that's how they've grown up. And I think that that's a very key component right now, because now they're thriving and striving in different areas that they may not have if I would have looked at them as being different than the other siblings that they have or anybody else in the world.
Thank you. And a similar question, Rasheera, and kind of talk to us about the work that you've actually been doing, via your wonderful platform that you have, and how you have been able to engage the disability community.
Yes.
People.
I think it froze there a little bit. I hope I didn't cut you off. So yes, I consider myself a disability activist advocate. And I look at disability, I kind of align with what the ADA says. It's just a person who has an impairment, whether that be physical, mental, emotional, or even under the lines with chronic health condition. And a lot of the work that I do, whether it's via social media advocacy or advocating here in person or through avenues such as research, which I believe is also a form of advocacy, is just really amplifying the voices of disabled persons, kind of like what you were saying, Jessica, normalizing the disability identity, that it really is a part of the human experience, the human condition. It's not a phenomenon, or it's not something that happens to special people. It's just something that happens to people. It's something that happens to humans. I think our society has really set not a good precedent on what disability is. And I think there's a lot of stigma that comes with the label. But like I said, it's a part of the human condition. And so I really try to advocate in normalizing disability. I believe the statistic says that 1 out of 4 people are living with a disability, which means it is so much more common than what we think it is. And so when we're able to put it into context like that, it's like your best friend has a disability, your parent can have a disability, your dog, animals can have a disability. And so when we think about it like that, especially in this conversation of health equity, we realize that it's not only for a small portion of the population, but it's for everyone. When we're talking about health equity and establishing equity and justice, disability is the largest demographic around the world. It costs, before the talk today, Michael Bray, we were just saying, it intersects beyond gender, disability, status, race, ethnicity, cultural, geographical restrictions. And so for me, like I said, that's what disability is making sure everyone is included in the conversation, everyone is heard, and that it is normalized, that it's human, and that's completely normal.
It is human. I really like that point you just made, Rasheera. Thank you, Michael. So I would really love to hear about your perspective, especially coming from the work that you have been doing with the Georgia Land program and in the disability center that you currently work in. So tell us about, again, answering the question, what does disability advocacy and health equity mean to you? And then some of the work that you've actually been doing in that space.
Thanks, Mitchell. I don't know where to start. I think what it means to me, being someone who doesn't currently personally experience a disability, is being a good ally. And it's always meant to me meeting people where they are, meeting them in the way they want to be met. So, I wear a lot of different hats over the years, and I think some of the biggest lessons I've learned in the work that I do with our University Center for Excellence in Disabilities and with our LEND leadership training program is to never assume. I've learned to listen a lot more, and I think obviously that's something we can all. I always feel that's something I can always do better. But listening to people, listening to their stories, learning about. We use the term lived experience a lot these days, and that could be applied to many things. But when it comes to disability, I think that it's paramount, whether you're talking to a parent, whether you're talking to an individual who experiences a disability. And like Rasheera said, we were talking about how the intersectionality of disability with virtually all other aspects of being human, and that someday, if I don't experience a disability now, but more than likely I will someday. We all will eventually if you live long enough. So it's just keeping that in mind, and I think being humble about it, and again, whether that's the work I do with designing instruction. I always try to work with. I don't know how I feel about the word stakeholders. I think we're all stakeholders in different ways, but I try to work with as diverse a population of folks as I can when, say, designing a curriculum or a training, because again, I don't want to assume that someone can access something just because I can. So I think that's probably the biggest lesson I've learned over the years. I just try to carry that into all the work that we do, and just listen a lot more, meet people where they are. And always be open to learning, because it's an ever-changing landscape. It really, really is. I think that's the message I always try to impart on discussing this with people.
And thank you for that, Michael. You mentioned a word just now, the word ally, and we often talk about the different. And it was even Rasheera pointed out in our presentation how much relationships matter. And so even though you don't identify as someone who is living with a disability, it does not mean that you can't have a connection or a relationship. So I guess the question for the group is, how important are relationships in actually advocating for and achieving health equity for people living with disabilities? And I'll throw it out to the group, whoever wants to jump in first. But I think I'll ask Rasheera to start and answer that question, because being that you have that lived experience, but you also consider yourself an ally. So talk about the importance of that.
Yes, absolutely. Great question. Relationships are so important. And I believe people with disabilities have a really unique experience that I feel everyone should adopt when it comes to relationship, because so much of our livelihood depends on relationships, right? We depend on being in community with people who can support us through our disability experience. What does that look like? So possibly when I go to the doctor, I may not be able to go by myself. I may have a caregiver, or I may have a parent, and that itself is a relationship. And so I'm dependent on that parent or that caregiver who is taking care of me, that relationship, to help me to be able to communicate to my doctor or to my practitioner the needs that I have, and vice versa. Jessica, you stated that you are a parent with you're a parent of 2 children with disabilities, and how that interdependent, because I don't like to call it codependent, because it works both ways, right? That interdependent relationship, that your children may depend on you to help them or to support them in their livelihood, and you depend on them as their mother. And so I think I always love that model of in which we hear a lot in the disability community spaces where we say supported decision making, like you're not here taking over or trying to control my life, but we are in this mutual relationship together, and how in that mutuality we are advancing health equity and pushing our doctors to not just take care of us, or not just to fix the deficit or what they think is wrong, or what is broken, but partner with us in our healthcare, partner with us in what our needs are, partner with us in accessing the things that we need to help to be able to thrive in our communities independently, with full dignity and with full dignity and full empowerment and full confidence. Relationships are extremely important.
Yeah, I could just add to that by echoing what you said, I suppose. Relationships are everything. I feel that understanding can only be cultivated through relationships. If you don't, you have to, but you have to work at it. I think, in a lot of the work that we've done, well, so in a very similar study that we did with telehealth and looking at disparities during the pandemic, our data was very similar. The outcomes were very similar to what Rasheera presented earlier. And one of the big themes of what we heard from parents, because ours was focused on pediatric care. So many of the respondents were parents of children with neurodevelopmental disabilities. And one of the big, they all loved telehealth, and for very similar reasons: less travel time, the time it took to prepare and connect, the ease of connecting in a lot of ways. But one of the big things is they said they would continue to use it. However, they still preferred to meet in person with their healthcare providers because of those relationships, because they have those very personal relationships. And Jessica, I'll throw it to you, because as a parent and parents I know, you form those bonds with those healthcare practitioners, your primary care doctors, your dentists, therapists, because you're seeing them so much. I just think that those relationships honestly are everything.
Yes, I would definitely agree. And so one of my children, my son actually, he has multiple specialists that he sees. And so I will agree, because one of the doctors, we couldn't do telemedicine. It was his orthopedic doctor. And so that's something we have to go in person, because we got to get x-rays every time we go, and they have to double check to make sure that the spine is still aligned. There hasn't been any increase, because he has congenital scoliosis. And so was checking that degree of curvature. Whereas the other specialists, we could do the telemedicine, and we did utilize it during the pandemic. However, when things became, I guess, more in the clear to go back in person, there is not a telemedicine option. It is come back in person, but I feel more confident going back in person, because we can have that one-on-one interaction, face-to-face. Hey, this is protocol. This is what we need to move towards, or we need to alter this regimen that we have going on. And it definitely does help with the relationship that you build, because I have been going to these specialists for, oh my goodness, almost 10 years, maybe beyond 10 years almost. And so over time, you've gotten to know who they are. One of them, I know his son is the same age as my son. And so we have conversations beyond just the care, but hey, how is your family doing? How's your son doing? Oh yes, Jaden's gotten bigger and your son has gotten bigger, and they're eating everything out in the house. But it goes to that relationship building. That face-to-face is kind of more of a personable level than the telemedicine, where it's just, I'm behind the screen, we're having a conversation, then it's over with. There's no room for the additional, conversation to be had.
You raised a great point, and even things we've been seeing in our study, and Michael kind of brought that up as well, of kind of those parallels of what you're seeing in Michigan compared to what we're seeing here in Georgia. and one of those are being utilized. So what tools, have you seen? Jessica mentioned the telemedicine. When we talk about access, when we talk about, we saw how people they have insurance to be able to take care of their, some of the barriers that you may have experienced when engaging people living with disabilities in actual in the actual community. So again, so Jessica, talk about telemedicine. Have you experienced any barriers in access? Rasheera also, I'll lobby it to you when talking and engaging with your peers, the type of barriers or the barriers that you yourself have experienced. And then Michael, what barriers to access?
I have experienced not too many barriers. I think my biggest barrier that I experienced was trying to figure out which platform was being used and ensuring that the link was sent on time. I prided myself on, okay, I get the link, I'm gonna jump on a few minutes early, but even with jumping on, I may be waiting on the physician to get on. I don't know if they were with the previous patient that may have lasted a little bit longer, or what have you, but just kind of sitting there and thinking, I hope I didn't miss the appointment. I hope I got there. I hope I have the right link, and kind of questioning things. And then, like I said, the other thing was getting on with the doctor and it not feeling like everything was addressed because it was limited in what could be addressed. They ask you the questions, you answer, but was everything handled the way it needed to have been handled in regards to, I don't have the machines at home to take the x-rays and say, hey, this is working properly, this isn't working properly, or to, do the extra things that normally are done when you're in the office. So those were the barriers that I kind of ran into when it came to telemedicine.
I like, Jessica, how you brought up that point. I think because we are still new in this telehealth space, although telehealth is not a new concept, it was definitely more newly used, especially during the COVID-19 pandemic. And so there is a certain level of trust of knowing, is the quality of care the same in person as via the screen? Knowing that because we're physically able to see, okay, the doctor is physically checking off the things that we're checking off. The nurse is coming in, she's taking my vitals, different things like that. And I too, even as a patient myself, I've had a couple of telehealth appointments during the past couple of years. And I was like, oh, that was really short. And, I hope that, it was supposed to be everything that it was. And so it is that little bit of uncertainty in the back of our minds, because I still think this is kind of a new territory that we're all in, that even though it is the future of medicine, making sure that quality of care is not diminished just because it's online or it's not in person. I will say that some of the barriers for myself personally in telehealth, and I believe we cover this in the study, is definitely the accessibility portion and the digital literacy. For me as a deaf and hard of hearing person, even making sure are the platforms that I'm using, am I able to get captions? Because depending on the day, most of us have been in the Zoom life for quite a while now. And depending on your internet connection and where you are and the tone of the person, it's like a hit or miss. So it's like, you feel like Charlie Brown over here sometimes, like, what did that person say? And so I feel like that a lot. Like I'm having like, can you repeat that? Or let me make sure I got everything, because technology is flawed. And so I think a lot of those things for me personally, that's what I have experienced. And that could potentially be a barrier, especially if it was like a life-threatening thing. Like if my doctor read me a prescription and I didn't hear it clearly, You know, that could be something that's life-threatening. Not saying that will happen, but that can potentially be a barrier. And then also, like I said, with the digital literacy portion, I think we have to not also, kind of like what Michael was saying, we can't assume that just because I understand that other people on the other side understand. And I think that's really important, especially when dealing with the disability community, because it's a large spectrum. And so some people, like I said, they may be supported or they may need support in accessing a different platform or utilizing or making sure they're fully comprehending what their practitioner is giving them, fully understanding the platform that they are using, and that they are able to fully access it. And I definitely think as we go into this new era of telehealth, that accessibility and accommodations has to be a priority. We cannot make all these systems of technology and make it inaccessible. And so I believe that there are a lot of disability advocates who are really pressing to make sure, are your websites accessible? Are they accessible to people who have low vision, who who are blind and seeing impaired? Is it accessible for people who are hard of hearing, even for people who have limb differences? If they cannot physically hold a phone, what are there options for these people to be able to access telehealth? Because what we don't want to happen is have telehealth and make it for able-bodied people, right? Able-bodied. I'm completely able-bodied, although I do identify in having a disability. It would be easy for me to pick up my cell phone and to use it. But for someone who has a limb difference or who may be a wheelchair user, I think we have to really be critical in thinking of every possible point and area that may possess a barrier to someone else, and making sure that we are eliminating those barriers and making the platforms as accessible as possible.
Yeah, I couldn't agree more. You know, what we've been hearing in Michigan is pretty much the same. We don't want technology to become yet another barrier to accessing healthcare. You know, again, it goes back to assuming. You know, I think in America we assume, oh, everybody has access to the internet or everybody has a smartphone. Well, that's definitely not true. I will say I just saw yesterday the I don't know if it's an act or a bill that came out of the Biden administration about access to low-cost broadband service. So that's a start, right? That's a pretty big deal. I know for a lot of folks in Michigan, and like Georgia, Michigan's a huge state geographically. Most of Michigan is rural. Outside of Southeast Michigan, outside of our 2 or 3 population centers, Detroit, Grand Rapids, Bay City, Saginaw area, it's very rural. I'm from Upper Michigan. I'm from the UP. It's all rural, and broadband access is a really big issue. Access to cellular service is a big issue. So again, I think we need to keep in mind that those things are still big issues for a large percentage of our population, and especially for families of individuals with disabilities, and being able to access it. And again, that personal piece is something that came out. You know, people still want to see their doctor, and in a lot of cases they have to for different types of therapy, different types of services that can't be delivered via telehealth. So I think keeping those things in mind, and remembering that there's already a gap in the availability and the ability to access services for individuals with disabilities and their families. We don't want to widen it. So we really need to stay on top of this, and this can be a wonderful thing, but we definitely need to be vigilant, and hopefully there'll be some commonality that can be brought to it, where access can be a blanket thing and not just access here, access there.
Well, I think that is a perfect place for us to end our conversations on today. I, again, just want to thank our wonderful panelists, Ms. Jessica Baker, Ms. Rasheera Dopson, Mr. Michael Bray, for joining us. Your experiences have been invaluable, and we just want to thank you, thank you, thank you. We hope that all the panelists will continue to enjoy the rest of our summit. And until next time, we'll see you all. Thank you.